Hello, everyone. Thank you so much for joining us for today's valuable discussion. I'm Allison Hamblin, President and CEO of the Center for Healthcare Strategies, and I'm so excited to welcome you to today's panel focused on how to elevate health equity in our approaches to identifying people with complex needs for care management and other supportive services. We have a great turnout today, reflecting how critical today's topic is to stakeholders responsible for the care of people with complex health and social needs. For those of you who are not familiar with us, the Center for Healthcare Strategies is a national health policy resource center that has a long history working with stakeholders across the nation to improve care for people with an array of complex health and social needs, particularly those served by Medicaid. Next slide, please. So what are we here for today? We are going to explore approaches to identifying individuals for care management and other services to address health-related social needs in ways that promote equity and ensure that our interventions have their desired effects. We're going to focus on why relying on traditional indicators like cost and utilization data may overlook underserved populations, and importantly, miss key people who can benefit the most from these services. We're going to talk about promising ways to define eligibility for these programs and services using more nuanced and expansive approaches than have been used traditionally. And finally, and perhaps most importantly, we're going to talk about how to prioritize equity in these identification efforts. Next slide, please. Today's event is spurred by CalAIM, which is California's ambitious statewide effort to transform its Medicaid program, which is known as Medi-Cal. Even though much of our discussion today will be talking about the California context, these issues are relevant to stakeholders across the nation, and many of you in the audience are doing this work in other states and regions. Accordingly, for those who may need it, here's a quick primer slide to familiarize you with CalAIM and related terms you'll be hearing throughout today's conversation. Two of the key initiatives under CalAIM are particularly designed to provide more comprehensive services for people with complex needs. And these include enhanced care management and community supports, the latter of which are services to address health-related social needs. Next slide, please. Before we dive into our presentation, I really want to thank our partners at the California Healthcare Foundation for their support of this webinar and for the companion brief that was released last week and from which we'll be drawing many of the themes and insights in our discussion. For those of you who want to learn more about CalAIM, the California Healthcare Foundation has a really comprehensive and evolving resource center that we encourage you to check out. And while many of these resources on the site are focused on California, others, especially those related to homelessness and partnerships with community-based organizations, are really useful and broadly applicable to people around the country. And in that vein, please note that the California Healthcare Foundation will soon be adding a section to the Resource Center on health and reentry, given California's recent approval of their request to cover pre-release services for people who are incarcerated. So please be sure to stay tuned for that in the weeks ahead. Next slide, please. All right, so for our agenda today, first we are going to hear from David Tian of the California Department of Healthcare Services on its equity vision for CalAIM. David is medical consultant in the Division of Quality and Population Health, and he's going to talk with us about how prioritizing equity when identifying individuals to receive newly available services is central to CalAIM's goals. After David, we're going to hear from my longtime colleague and now independent consultant, Rachel Davis, who is a leading expert in complex care across the country. And Rachel is going to share takeaways from our recent research on today's topic. And following her presentation, we are going to have a really robust and interesting discussion with some fantastic panelists who I will introduce momentarily. And finally, we will wrap up with a brief Q&A session based on questions submitted by our audience during the registration process. I would encourage you to feel free to submit additional questions using the Q&A tab at the bottom of your screen during today's event. And though we may not get to them today, they will be really helpful to inform future explorations, even if we don't field them in our discussion today. So please feel free to use that option as you see fit. Next slide, please. Okay, so I've already had a quick opportunity to introduce David and Rachel, but in addition to them, we're delighted to have a great group of speakers and panelists today representing deep expertise in ways to improve care for people with complex health and social needs in California and nationally. So in addition to David and Rachel, our panelists include Chris Esguerra, who is Chief Medical Officer at the Health Plan of San Mateo, where he oversees programs that serve more than 160,000 people in California's San Mateo County. We are also joined by Clemens Hong, Director of Community Programs at the Los Angeles County Department of Health Services, where he leads the county's implementation of CalAIM. And finally, we're joined by Jonathan Weidman, who joins us to provide a perspective outside of California. Jonathan is Vice President of Population Health for Care Oregon, which is a Medicaid managed care organization widely known for its expertise in complex care approaches. So finally, thanks again to all of you for joining today's rich discussion. And without further ado, it's my pleasure to invite David Tian from DHCS to share CalAIM's vision for equity and the importance in this context of nuanced identification strategies. Thank you, David.
Great, thank you so much. And thank you for the opportunity to participate in today's session. My name is David Tian, and I'm a primary care general internist and addiction specialist and one of the medical consultants, as mentioned, on the population health team at the Department of Healthcare Services of California, which is our Medicaid agency. And on behalf of DHCS's Pop Health team and our Quality and Population Health Management program and our Chief Quality Officer, Dr. Paula Barberia, it's my pleasure and honor to offer some framing comments for today's session within the context of CalAIM. Also, thank you to CHCF and CHCS for holding today's session and providing continued leadership on improving the healthcare of Californians, and especially Californians who are served by our Medicaid program, Medi-Cal. The Department of Healthcare Services is really excited to learn with you today about how to prioritize equity in the identification of beneficiaries for care management services, as CalAIM seeks to offer whole person care that pays attention to the preventive, medical, behavioral health, and social needs of Californians. One of the key questions lies in how we can avoid perpetuating systemic bias into Medi-Cal programs. I'm actually reminded of a reflection piece that I conveniently read this morning in the Journal of the American Medical Association, in which the author, who's a physician, asked how healthcare could draw out and honor what she calls stories that we don't know about patients' family histories of health conditions. She noted that her own family had been systematically excluded from healthcare, and due to that systemic bias, health conditions that were passed down from generation to generation went unnamed and unidentified. Thus, our existing methods of uncovering risk, taking a family history for health at a healthcare visit by asking, what health conditions run in your family, under-identified these risks until this generation, when the author's family finally broke through the systemic forces that made the healthcare systems so unavailable and unwelcome for so long. And as we know in our work on CalAIM, many of our health systems, healthcare systems, and other social services systems still remain unwelcoming for so many people in our communities due to systemic bias. DHCS is particularly aware and attentive to the risks of anchoring only on the stories that we know, stories that generally focus on higher utilization or emergency department presentations and readmissions. These stories are necessary but insufficient ultimately to achieve our shared purpose of improving health holistically as opposed to only focusing on healthcare services. As we engage in today's session, I'd like to prime us to think about risk in a broader, more holistic way that is inclusive of risk of underutilization, as well as social outcomes that may cause harm and even death. Today's discussion is particularly timely as the department launches monitoring for pop health management later this summer. New key performance indicators look at primary care engagement and utilization, measurements that are actually absent from quality measures and most nationally recognized benchmarks. And some of you are also serving on our scientific advisory committee for California's effort to build a risk stratification and tiering model to identify risk for our Medi-Cal program. an effort that is transparent and seeks not only to look at utilization and emergency department presentations and so forth, but also outcomes of underutilization, delayed or missed care, as well as social outcomes. And all of this is to say is that DHCS is keenly interested in the area of today's discussion as a continued mission critical area of focus. And so I want to turn the stage over to our content experts today, but I'll leave with some questions around how we might identify and listen to and respect and honor the stories that we don't know. How do we fill out the picture of how Medi-Cal beneficiaries are doing in their communities? How can we engage people in communities that have been systematically excluded so that we don't continue excluding them in new programs, especially those focused on addressing social drivers of health, such as enhanced care management and community supports? How do we equitably identify needs of people who have not engaged with the healthcare system previously? And with that, I'll turn it over to Rachel Davis for her presentation, and I look forward to learning with you and continuing our discussion during this session.
Thank you so much, David, for that really helpful framing. And I think that gives a really excellent foundation for the rest of today's conversation. So the impetus for today's call really grew out of a question that our partners at the California Healthcare Foundation had, which was how to ensure that enhanced care management and community supports are being offered in ways that prioritize racial equity and ensure that underserved groups aren't being left out. So we started by examining one of the most commonly used approaches to determining care management eligibility, which is using cost and utilization data, typically from emergency department and inpatient visits, to identify who has high risk. And then we used what we learned from that line of inquiry to highlight some broader lessons for how to think about developing eligibility guidelines and identification approaches in ways that intentionally center equity and impact. To do this, we reviewed literature, we spoke to several experts in the field, including a few who are on today's panel who have experience developing high-risk identification approaches. And I'm going to quickly share what we learned through, to do this, we reviewed the literature and spoke with several experts in the field who are on today's panel. And I'm going to quickly share what we learned through that research and those conversations. But Emily, if you could go to the next slide. I did want to point you to this brief, which Allison also mentioned, which was published just last week, and it summarizes our research and goes into a lot more detail about what we found and how those of you doing this work can take some of the lessons and put it into practice. So this brief is a really great companion piece to today's conversation, and I really encourage you to go to the CHCF website and check that out. So Emily, if you could go to the next slide, please. Very briefly, I'm going to provide some of the high-level takeaways of what we learned from our research and conversations with experts. And the long of the short is that there are reasons to believe that relying on cost and utilization data may perpetuate inequities and overlook key populations in a few key ways. So first of all, this approach might overlook people of color. I'm guessing that many of us saw the study that came out a few years ago that found racial bias in a widely used commercial health insurance algorithm that was used to find patients for high-risk care management programs. And I think that study really underscores that approaches that rely on cost and utilization data don't adequately factor in the barriers to accessing care that we know Black, Latino, American Indian, and Alaska Native and other members of underserved groups experience. We also found that some people might get overlooked if we're defining high needs by looking only at emergency department and inpatient cost and utilization. So for example, you might miss people with other types of high utilization, such as folks who have large numbers of prescriptions, or you might also miss people who have certain conditions that could indicate complex needs. We also heard that when we set very high cost and utilization thresholds for determining eligibility, we might miss people who are rising risk, that is, people who are on a trajectory to develop high needs and who would benefit from care management and supportive services, but are not at the very highest levels of cost or utilization yet. And lastly, we heard that identifying who has high risk is not necessarily the same thing as understanding who might benefit most from care management and supportive services. And so relying on this type of approach may not always lead to providing services in the most impactful or efficient ways possible. Next slide. So even for programs that don't rely exclusively on cost or utilization data to define eligibility, and to be clear, CalAIM actually only does this in a few instances with enhanced care management and community supports. I think there are still some important lessons in this case study, in this conversation, both for the plans in California and for those of you on this call today who are doing this work nationally, for how to think about ensuring that you're prioritizing racial equity when developing identification and eligibility approaches, and really focusing on offering those services to people who could benefit most from them. So some of the approaches that we heard from experts that could help promote this include making sure that you're baking an equity lens into your approach right from the get-go, and then continually assessing how you're doing on that front by doing things like stratifying or analyzing all of your data regularly by race and ethnicity. You can also consider developing a more nuanced definition of need or high risk, and consider doing things like looking at underutilization, not just overutilization, and thinking about pulling in data from lots of sources, especially those that can help give a picture of health-related social needs. And then lastly, we heard a lot about how valuable it can be to create referral pathways from those who know patients and their circumstances in up close and personal ways, and really in ways, as David was just speaking to, in ways that we can't get from data from claims or EHRs or assessments. So that was really the CliffsNote version of our finding. And again, I encourage you to check out the brief for more details, but I hope that that was useful context and background for the rest of today's conversation. And I'm thrilled to turn to our main feature here today, which is going to be a panel that includes a wonderful group of practitioners who have spent a lot of time grappling with these questions and testing out approaches to addressing them, and who have really kindly agreed to share some of what they've learned with us today on this webinar. So I'm going to invite our panelists to turn on their cameras and their microphones. And just as a reminder of who our esteemed panelists are, we've got Dr. Chris Esguerra, who's the Chief Medical Officer at Health Plan of San Mateo, Dr. Clemens Hong, who's the Director of Community Programs at LA County Department of Health Services, and Jonathan Weedman, who's the Vice President of Population Health at Care Oregon. It's great to see you all. Thank you so much for joining us today. We're going to spend about 30 minutes in conversation with them, and then I'm going to turn it back to my colleague, Allison Hamblin, who is going to pull back David into the conversation for some reactions about how this all connects back to the opportunity to ensure that programs like enhanced care management and community supports are really reaching the right folks. So without further ado, let's jump into some of these questions and get this conversation going. So Jonathan, I think I might start with you, and I'd love for you to speak to what Care Oregon has done to think about racial equity more intentionally when it comes to developing care management, eligibility guidelines, and identification approaches, and why you've developed these approaches, and what you've learned from having to go through a couple of iterations of them.
You bet. Thanks so much, Rachel. And thanks everybody for having me. I love to talk about this subject. So yeah, I think, and David said it best, which is, what is the story we don't know? And I think that's been the journey for us, certainly at Care Oregon, and I'll start by a quick story myself. When we're thinking about data, data can be used to create access or block access. And that is something that I think is always really important to think about in terms of an equity lens. And then just this beautiful saying that we've heard, in pop culture, but is very true, which is that, with great power comes great responsibility. And I think data is powerful and a powerful tool. So we got to be really thoughtful about how we use it. And then just this concept of how different communities use the health systems differently. And so I think you've got to explore what are the larger nuances of how folks use the system if you're going to use that to create access. So anyway, my quick story though is a few years ago, we as we were kind of diving into this, creating the Pop Health, initiative for ourselves, I got really excited. We had just built this, what I thought was this incredible population segmentation algorithm. I thought we were going to do this really amazing stuff, which we did. But I got invited to this group of culturally specific providers who really wanted to have a conversation about how they could really tell the story of the complexity of their work and have that reflected in payment, right? Makes sense from a health plan perspective. And I got really excited. And then I was like raising my hand and saying, we can give you all this data. We have all this great data we can share with you. We have this new segmentation that we're doing. And this very wise person in that room was very kind and just said, I think we're going to hold off on all of that because data has historically been used to, have power over our communities. And we really want to have a much more broader conversation about how this data would be used and what goes into it. And I at first felt, a little bit ashamed, but then I really remembered my own community, right? As a queer identified man who grew up through the 80s and saw what AIDS did to my community, information and data was used, to really block access a lot in terms of research for gay men and those kind of things. And so it really kind of helped me take a step back and go, wow, we have to start thinking about how this looks different. And classically, we had programs at the time that were really built as like utilization programs. So if you met a certain threshold, you could enroll in the program. And if you didn't, then we waited for you to become a high utilizer, and then you could enroll in the program, which didn't really make sense. And we would hear from providers, hey, I know this person is going to be utilizing healthcare more. How can I get them in more proactively? And at the time, we didn't really think about it that way. So, and we realized once we started kind of disaggregating our data, we were missing a lot of key people. We were missing key communities that were, again, using the system completely differently. We noticed that communities of color were not accessing the ED as robustly, for example, but then when they did, they were very ill and then they were in the hospital for a long period of time. And so we started to kind of look at it a bit different to say, how do we actually open up access, allow anyone who has an issue to come into the care team, and then we triage appropriately into what program is the better fit versus saying you have to build a program around a person. We're really building all of this around how people are need things, right? So someone may come in and just say, hey, I just need this one thing. I don't want anything else from you. Can you help me with this one thing? And we can address that, and that's great, and move on. And then if someone needs more long-term support, we have those programs available for people too. So really changed how we open up access. Also that anyone can refer. So a community-based organization can refer in, a member themselves, a patient themselves can refer in, a provider can refer in. Again, not us kind of creating a pathway, but saying like, you tell us how you want to engage with us. And I think that really helps tell a different story and allows us actually to have a lot more access to people in a more open and organic way versus us trying to get really prescriptive about how we can, find folks proactively in that space. So I think, ultimately for us, it has been this journey. It continues to be this journey around who are we missing, applying that equity lens of once we create something, who will we miss in this process? And intentionally asking that question and finding the answer to say, this specific thing is going to leave out these kinds of folks. So how do we address that and think about that? And then primarily listening to our communities, our culturally, specific providers who come and say, this isn't working right, or you're missing this part, or this isn't how folks are using this system, has been really, really valuable. And again, you can't capture that in a data point. It's more that qualitative data that's very, very helpful for us. And it has really changed kind of how we've started doing this work.
That's wonderful. Thank you so much for providing some of the details of your experience and evolution there. And Chris, I want to pull you in and kind of build on that from the California perspective, because I know Health Plan of San Mateo has been really innovative in the way that it's thought about some of these issues. So just as context, DHCS, California State Medicaid Agency, has provided eligibility guidance, but also some flexibilities to manage care plans when it comes to figuring out who to offer enhanced care management and community supports to. And we're seeing a wide range of responses to this from managed care plans in California. Some are really embracing these flexibilities and taking them as a floor rather than a ceiling for who to offer services to. And some are sticking to, what's on paper, the narrow definition of eligibility as it's been, put out there by DHCS. So I'm curious if you could just speak a little bit to how Health Plan of San Mateo is thinking about this issue of who should be pulled in for these kinds of care management services and supportive services. And maybe if there's an instance where you guys have intentionally gone broader than DHCS's eligibility criteria, if you could speak to what that's looked like and why you've gone in that direction.
Oh, definitely. And thanks for having me. So I wanted to just really underline something Jonathan pointed out and just kind of make it even more explicit. It's really this intentionality of thinking about the power dynamics and how is it that we flip it. And power dynamics from the sense of, data aggregators, that's what we are really on the plan side. We have tons of this information, and how is it that we intentionally use it? And then also just this idea of how is it that while us plans may feel more that we're following along with what the state is wanting to do, or our regulators, it's how we're actually implementing these pieces and in a way that is actually for our communities, that is intentional. And so the thinking really, when CalAIM came out, especially for enhanced case management services, there was also the thought that these are for our individuals that are our highest utilizers, the top 5% of our population. And of course, thinking about it based on the utilization perspective, we're definitely missing a number of individuals as a result. And really, it boils down to that systematic history of when healthcare has not been accessible, has actually not included populations, individuals. And as a result, we're not going to have data in that. It's a lack of trust in the system. And so in our own stratification, we thought through then, yes, we'll have utilization information. That's actually the relatively easier part. Jonathan will agree with that. It's the negative spaces that's actually harder. What are the proxies for lack of access? There's some easy ones, lack of primary care visit or any provider visit in the last however many, pick your time period. But then there are harder ones. And what is it about, how is it that we think about those proxies? How is it that we think about other means of getting that information? In California, we do have some unfortunate carve-outs as well. As plans, we won't see that information, behavioral health on the specialty mental health side. Typically isn't necessarily that we won't see that information, or if we do, it's a little bit older, 6 months or so. And so what are then the partnerships that we need to forge to be able to get information otherwise that we wouldn't necessarily have? So starting really with that premise and then thinking about what is the intent when we're thinking about the populations of focus from the state's perspective. And the nice thing actually for a lot of these definitions, especially enhanced case management services, is that we don't necessarily have to start with the data, the utilization components of the top 5%, we'll use that in quotes. We'll start with the population of focus. Why don't we go ahead and center that? And by centering that piece, I think it moves you away from the thinking about the data and what you have, and instead allows you to focus on how is it am I going to actually identify this particular population? How is it that I'm going to work that much harder to really have a better sense of how we begin to target and think about the programs? So thinking about, say, our unhoused population. Very hard to have data on that. And yes, you may have a subgroup that may have high utilization, but that's because they are either incidentally interacting with healthcare, or they know how to use healthcare from the perspective of the emergency room is a place where I know I'm going to get certain needs. But that's a subgroup. And then we have another group that will never have any interactions with healthcare, but may have interactions with other aspects of the community, other community-based organizations, county-based programs, things like that. And so the idea here, in addition, is how do we even identify someone who's unhoused? We have potential proxies in our system. We have some ideas of how to do that, but that in and of itself is a challenge. And so while we work to have some level of integrity in terms of flagging someone who is likely to be unhoused, their address is an address that is likely where they actually signed up for Medi-Cal. Their address is actually our address, or a provider's address, for example, or maybe if we're lucky, we have a Z code sent in by a provider that's relatively recent. But we know that's really not helpful, because this is it's not something that it's real time. And so this is really coming in and working with our community partners, our county partners, to really help us in that identification. They have the knowledge, and how is it that we're able to share that information with each other to be able then to have those referrals and surface those referrals in. So we really thought about it as not just about we identify and then that's it, that's our population. It's really then how is it that we partner with our community, our county, to actually be the ones to identify and actually have a process by which then we're actually able to enroll those individuals and get them started. So you need to have both. One does not supersede the other. And that gets you then into something that's a bit more robust. And it's actually trickling into other areas. One of the interesting things, we take a look at our outcomes in general from an equity perspective and do the risk stratification or stratification by a number of factors, race, ethnicity being one of them. And one of our outcome measures, we saw very much a disparity, in particular for our Black identified women getting breast cancer screening. We looked at the data, said we saw that, and then we started asking questions. Instead of just starting to do let's do a campaign, let's have an intervention. Turns out it wasn't just about awareness and engagement with the community. There was some data issues with our providers in terms of actually being able to make sure the information was flowing to us. Because had we gone ahead, we probably would have been annoying a significant number of people who already did something. And what a great way to alienate them further from a healthcare system by being annoying. But I think here the idea ultimately is in thinking about populations and stories that have historically been ignored, how is it that you center them into the work and then do the work of trying to figure out what other pieces of information, being humble about that you don't have that information going in, but still being able to elevate those populations into this algorithm. It makes it a lot harder. It's not so simple as I just have these data points coming in, but it actually moves you away from, I think, Jonathan, you also said this a little bit too, historic frameworks where you kind of have to fail first before you get the service, and instead allows you to be more of a responsive system to really then tailor to that experience of the individual.
That's great. Thank you so much. And I hope that it's helpful for folks on the line to hear about how you guys have used the guidance that DHCS has put out there as a starting point for thinking expansively about what does it really mean to pull in this population of focus who, if we're just relying on some of these traditional data points or approaches to understanding who meets this definition, might we be missing? Thinking really critically about going beyond all of that and using some innovative approaches to doing so. So I really appreciate you speaking to that perspective. And Clemens, I'm going to pull you in here because I think there's sort of another companion concept to what we've been talking about today. Some of these traditional approaches might be overlooking some populations, and some of these approaches might be pulling in populations that aren't necessarily best served by care management services or supportive services. There might be some folks who could be really impacted by these services that we aren't necessarily finding when we're just looking at things like cost and utilization, or not thinking necessarily as expansively about who to pull in. So I'm curious, because you have been both on the program side developing approaches to try and identify people, and you've researched a lot of complex care programs. What have you seen as being the keys to successfully offering these services to the right folks? And what have you seen as some of the stumbling blocks to maybe not necessarily pulling in the people that you can be the most impactful with?
Yeah, thank you, Rachel, and thanks everyone for having me and for attending. I think a great place to start is where something Chris mentioned multiple times, which is really to center the population of focus, right? And I think successful care management really starts with clarity on the population of focus and the desired outcomes and timeframes for those outcomes, right? A program that's targeting a 6-month reduced utilization readmission rate is very different than a program that's looking for reduced acute care utilization over 10 years, right? In terms of how it's formed. So once you have the population of focus and the outcomes clearly delineated, you really need to identify a program design that's going to work for that population. And this is where I'll spend a little bit of time, because I do think that a lot of the lessons learned comes in this space. So how do you identify and engage the population of focus? How do you identify opportunities for improvement and then successfully deliver effective interventions, right, to achieve those desired outcomes over the time frame you want to see them? So what we know is that identification really starts with that population of focus. And I think we've heard that already today. Broad-based algorithms are really just a small piece of the bigger puzzle. And if you just take a big list and you start going at it, it's not going to get you to where you want, right? So we've often looked at hybrid models. So how do we take into account both data and knowledge of the individual that's available to those people taking care of them on the ground, right? Can we identify individuals who may not show up in high-risk data sets, right, due to underutilization of care in certain marginalized populations, or due to varying elements? And you've heard some of this from Jonathan, that small subgroups may use the system differently. So we may not pick up using broad-based algorithms those folks, or identify those who were high risk yesterday, but are going to be less high risk today, right, which we often see with data lag. Or lastly, to identify people who are most impactable by interventions. I think this is, Rachel, where you were going. I think this is especially true in Medicaid populations, where predictive data gaps are much greater because of the needs of the population. And so once you've sort of done this identification, you need to engage the population. I think these engagement sort of approaches are really critical. And often the identification pieces are separated, right? It's like you've identified this population, now go after them, make a bunch of phone calls and engage them. But it actually isn't the best way to engage people, right? So we need to think about how we go about sort of doing that with this population of focus. And I think, you know, point of care engagement is really the way to go, right? So how do you sort of, as a health plan, push information, right, to the points of care on these folks that are going to meet your algorithm definitions of high risk, so that we can reach them, rather than giving them a managed list that they need to call, right? And I'll tell you that in our enhanced care management programs in primary care, our nurse care manager is a very expensive resource, spend hundreds of hours a month just calling people with wrong phone numbers or trying to chase people down. So that's zero impactability, right? If you were to really think about it, if you can't engage them at all. And so I think really thinking about that. The second critical component of engagement is trust. How do you sort of build trust with the population? This is, in my mind, the foundation to all, right, care management interventions, care interventions in general. It's often overlooked as to how we sort of build that trust. So one of the things I mentioned before is critical. If you engage them at a point of very high need, which is what we've learned from Camden and a lot of other sites, like in the hospital when they're sick, or you meet them where they are, as we're sort of finding with street-based engagement or interim housing-based engagements in the housing space, and use trauma-informed principles, I think then you have the start point from which to build it. And so I think we really need to think about, as a strategy, not just how we identify people or how we're pushing data to places, but how do we then leverage teams in the right way that are trained in trauma-informed care, that have that bring shared lived experience to the table, teams that have community health workers or social workers that come from the community, that speak their language, right, the language concordance issues, or are transgender, right, themselves, or whatever the sort of need may be. I think too often we sit in our facilities and we call people, we wait for people to come to us rather than engaging them where they are. And I'll say that in our, in LA County, our street-based engagement teams have been so critical, right? They're meeting people on the street. They bring the services to them. And they often don't start with treating their diabetes, right? They treat their substance use, they treat their other things, they give them food, right? And these engagements take weeks, months, or even years. But I think that sort of piece is critical. And how do we sort of, cover that engagement, right? So that these high-risk individuals eventually get that care, right? So I think that that's critical. And then finally, I think once you've assessed needs, right, in the population, you need to deliver effective interventions. I think, this is less risk prediction, but we don't often know what interventions work for specific populations. But the piece that is really tied to risk prediction is we often have algorithms that predict risk in very sort of narrow ways. So the example I use is we'll identify someone who's at very high risk for physical acute care utilization outcomes, right? So for instance, they have congestive heart failure. We know that they're just getting admitted over and over again. But what we don't know is that their mental illness is keeping them from taking their medications, and they're using meth on the side, right? And then we don't invest in the strong behavioral health interventions that then help us change the trajectory of that person. So this speaks to that impactability. So we've essentially chosen the wrong population because we don't have the infrastructure resources invested in the right place to impact that person's utilization. So I think it's really critical for us to kind of think about those pieces when we think about these sorts of interventions. So, I think just in summary, I think that these identifying algorithms are really just the start point, and it's definitely not a panacea. I spent a lot of time researching this and trying to identify ways to get proxies for enabling features or all sorts of things you can try to identify in the data. But at the end of the day, you can't really substitute for how you sort of design these programs and leverage the people and multidisciplinary teams on the ground to sort of achieve this. So I'll stop there.
That's great. Thank you. I think one theme that is sort of cutting across all three of your comments is that you need to think outside the box. You need to go outside of some of these traditional data mining approaches to find the right folks. And I think implicit in that, and some of you have spoken more explicitly about this, is that there are other partners and other resources that you need to collaborate with, or that you need to draw on to really effectively find the right folks, serve the right folks with these types of programs. So this is a question for all three of you, just in our last few minutes of this panel here, but I'm wondering if you could speak to, what have been the key collaborations, what have been the key resources for you as you've thought about really maximizing your ability to find the right folks for these programs. And maybe Jonathan, I'll start with you and then turn to Chris, since you guys can both represent the plan perspective. And then Clemens, we'll have you wrap up from the healthcare partner perspective.
Yeah, I really appreciate it. And exactly what Clemens was talking about, which is that the starting point is really just the concrete, discrete data we have. And that's great, and that's good, and it serves a purpose. But then there's a much deeper, meaningful level of engagement that you can use that with. And I think Chris said too, so really tapping into community-based organizations for us has been really helpful. Tapping into existing programs that are really on the ground, as Clemens was saying, doing this work. I'll give a quick example. We saw in our data a real need to create some sort of meal delivery program for new BIPOC moms is a good example, right? And so we were like, okay, but how do we understand what's happening? Because they're not utilizing our current benefits. So there's something going on there. And we engaged a local program that worked really closely with new moms in the region. And we sat down with them. We asked if we could meet with some of their patients. And those moms said, well, there's a couple problems with this meal delivery you have. It's not culturally specific, so I don't want to eat that food. And you only bring food enough for me. And I have a family to feed. So there's no point in you bringing a meal for me. Bring a meal for my whole family that is culturally specific, and then that would actually help me, right? Like I really need the help, and that would be helpful. And it was a game changer, so we found a local, culturally specific caterer who was willing to put the food together and deliver the food. We delivered it for the whole family, and it really did change our outcomes in terms of like breastfeeding and, stress levels for moms and those kind of things. Never would we have gotten that information from anything discrete in our data. It took us seeing a little bit of a picture and then really honing in and having the bigger conversations. So I felt like as everyone was talking, that was a perfect example in my head that was like, that's where you get the gold. You really see what it really means for people. And then to Chris's point, then we're not irritating or creating further distrust into these communities that have a long history of distrust. So anyway, I would add that to the conversation.
Yeah, that's huge, Jonathan. And I think like two things I guess I'm thinking about. One is the partnerships with community organizations or county organizations. Very, very important. And I think a great example there for us in San Mateo is our close working relationship with our county behavioral health organization. And understanding that, again, California, we have that as a carve out on the specialty side, also on the substance use disorder treatment side of things. And what we've worked to do is not just have the partnerships in terms of the work, they're actually, the vision of theirs actually is one of our ECM providers, but also really thinking about it from a data perspective. And really thinking about it of what are the structures that we need to not just share data to allow us to actually be able to act on certain things. So we have some really cool things that we were able to do in terms of emergency room visits and follow-ups as a result, because now we're actually getting data from each other. We're working towards then getting some interventions. One, we didn't get the data before, but by just getting the data, doubled our rates. Turns out stuff is happening. We just didn't know. And now we can do more on top of that. And then there were some interesting structures on actually even sharing substance use disorder treatment data by way of, because of the limitations around 42 CFR Part 2, which governs that area. But there are some actually interesting ways that we have had an agreement over the years to actually be able to use and share that information to actually further help along with coordination. But the other piece too, I really want to highlight, and this is what Jonathan was really thinking about, is we can do the work with the data, but this goes back to attending to power dynamics and really having that sense of humility about all this, is then going out and validating, going out to the community and asking, this is what we saw. Is this your experience? And as much as it's easy for me to say that, to do that, it's really hard to build those structures that you actually have that kind of community input, especially if perhaps you may not have been doing it before. And how then do you begin to do those community discussions, partnerships in a way that's not extractive, rather it is one of a partnership. And we're continuing to work through that. It's an ongoing thing. We acknowledge that we're not there as much as we would like. Ideally, we'd love to get to a place of community co-design, and a lot of that what we do right now, it's advisory. It's like, we did a thing. Can you tell us more about the thing? As opposed to, let's invite you right from the beginning. And how do we begin to do that? That's hard. It's a journey, and we're working through it. But I definitely want to advocate for that, because that's another way of centering and addressing power dynamics as well.
That's great. Clemens, I'm going to give you the last 60 seconds here before turning it back over to Allison and David.
No, I think I'll just start with where Jonathan and Chris left off, which is really centering community is such a critical piece here, particularly for the most marginalized populations. The community-based organizations, community members have the trust. And I'm going to build off of what Chris said, and we need to bring community members onto our teams, into our leadership. We need them to co-design, as we're talking about, and advisory boards. All of those things need to be done with a model for providing agency and resources to providers and building their capacity. And I think that piece is so critical. We have over 150 community-based organizations contracted with us, but they're a subset, and there's a lot of mom and pops out there that don't have the capacity to do that, but they have a lot to bring to the table, and we need to kind of build their capacity to do this. A lot of these entities could be behavioral health organizations, could be a host of other. They could provide a host of other services in the community, and it's really critical. And then I think, I really center a lot of the work in this space on justice. I think, unfortunately, many of our most marginalized folks touch our justice system, and how do we sort of engage our justice partners in a different way around health to sort of bring that? I think that's another entity I'll call out that I do think warrants some consideration. We do a lot of that here in LA County in terms of diversion and reentry programming. And I think and thanks to the state, and David's on, but a huge equity impact is going to come from our 90-day pre-release sort of work and really tackling the inmate exemption, which is, one of the possibly best ways to impact health equity from the perspective of policy. So huge props there.
Rachel, thanks for inviting me back into the conversation, and Clemens and Jonathan and Chris. Thank you so much for these remarks. I know we all knew coming into this panel that we could do this for 2 hours, not one. We're going to leave so much uncovered here, unfortunately. David, welcome back to the conversation. I'm sure we've all been jotting down our notes here. One of the powerful quotes for me is, how our communities where there's the biggest lack of trust with the healthcare system is where we have the biggest lack of data. That's one of the manifestations there. And there's been so many other rich insights shared as well. Just want to turn it back to you. Based on what you heard, where is this landing for you, and what would you urge our stakeholders in the audience to think about more?
Thank you so much. And I think I will mainly lift up some of the key points that I took away insofar as that was such a rich and inspiring set of presentations and discussions that we just heard. I think I wanted to lift up what Jonathan said regarding how data can be used to block access or that we can act proactively. I think that, DHCS certainly favors the proactive action rather than the data being used to block access type of approach. However, I'll take this as an opportunity to lift up that in terms of how we view care management, for instance, there's a whole range of benefits and services that should be available to members outside of enhanced care management to address things like rising risk, as was lifted up. And so there are things like basic population health management services that should be available to all beneficiaries, such as ones focused on preventive care and care engagement, as well as things like the community health worker benefit and complex care management that can be really leveraged to address rising risk before there's a crisis or something that would qualify someone to meet the population of focus criteria for enhanced care management. I encourage the spirit of leading with how we can make people healthier in our communities, or help them, empower them to be healthier is probably a better way to phrase that. And a good example would be medically tailored meals and culturally appropriate ways. I used to work at a medically tailored meals organization, so what Jonathan mentioned about culturally appropriate food rings true regarding some very strange salads that we used to send out into the community that were experimental, and I certainly was not familiar with. I think that the other thing I wanted to lift up would be this idea of data being the floor and not the ceiling, and starting with populations of focus. I think that this was so critical, insofar as what Chris mentioned regarding this type of spirit, just because we have an inkling of these data and these populations of focus or communities, but we are probably going to be missing information. So what Chris mentioned about collaborating with healthcare systems, for instance, and behavioral health systems of care, or to actually think about how we get better data and actually incorporate the experience of people who need these services is absolutely vital. There can be low-hanging fruit, such as just having the data, but also thinking about data that we probably won't ever get through claims administrative kind of data that is coded. As a provider, please don't make me check one more box type of deal. But I think that what are ways that we can do this smarter, or actually think about proxy measures, as Chris mentioned, that may not be readily apparent in administrative data that we're used to looking at for, say, quality measures. And finally, I think this theme that all of our discussants brought up, including trust building and humility. I think that enhanced care management is designed to be a community-based benefit insofar as managed care plans are required to contract with community-based organizations. And the spirit of that actually is exactly what Clemens and Jonathan mentioned regarding these collaborations and existing relationships that community-based organizations often have with people, and offering things that people need that may not be readily healthcareified, as I sometimes say. If someone needs something that is a basic need, for instance, we are starting and increasingly paying attention to those needs now within things like enhanced care management, community supports, but other people have been doing this the whole time. And I think that these organizations are well suited to have trust and, honestly have treated people with more dignity and respect than healthcare settings have and traditionally done. And these are kind of key partners. And, we are trying to honor the role of these trusted health partners through things like these benefits that engage the community, but also through community health worker benefit, doulas, peer support services specialists, and so forth, these new benefits and Medi-Cal that hopefully will empower some of these organizations to leverage healthcare sources of funding and programs to sustain, build their programs, and also continue to engage in the community. And so I would just say that those are my kind of high level kind of conclusions and themes based on today's discussion. But I think certainly, as I mentioned before, we are very, very interested and will continually be lifting up and highlighting how we can incorporate the stories of people that are unheard, and unknown as we continue to build out Cal-AIM and the enhancements to Medi-Cal that hopefully will help increasing numbers of Californians.
David, thank you so much for that. And thank you for bringing us back to the stories we don't know, which was such a powerful way to open up this dialogue. We have 4 minutes left, which is not enough time to field additional questions, but I might just ask our panelists to think up here. I'm going to give you like 10 seconds to think about, like, based on this conversation, if you had to pound the table with one piece of advice that you hope our audience takes away from this, maybe one thing that they're not doing today that you would encourage them to do differently, based on this conversation, would love for you to share in a lightning round, maybe 1 minute each or less, that advice for folks. So maybe we'll go in reverse order this time. And Clemens, I'll start with you.
I think the data and engaging the communities and the populations of focus, right, and discussions around how to identify if that's really where the focus of the conversation. I think that's a really critical piece, is how do you bring them to the table in a way where you confer agency, where they have an equal sort of capability of putting their ideas forward and have it be incorporated. So.
Thanks, Clemens. I love that. And it reminds me of Chris's comments before about, ultimately trying to get to co-design, but recognizing there are really valuable things to do on the journey to co-design to engage more in partnership with the communities that we're trying to serve here. So thanks for underscoring that point. Chris, I'll turn to you.
I just want to call out this interesting framework, and relatively recently I learned it, and just from a great speaker, but it's this idea of the healing arc. And it's this idea of, for those stories and populations and people we have ignored, whether systematically or however in the past, and we actually want to do better for them, for their communities, place them at the center, and not just do the typical statistics and trying to figure out what to do. Push it forward and really lead into what you don't know, and really lead into understanding. And that gets into the power dynamics component, that gets into a justice framework more than just the equity component. You don't necessarily want to just make it equal, you want it even better. And I think it's a much more interesting way to proceed, and takes you out of the I need to get more data. It really gets into more of, how do I actually then begin to engage with this community, with the community, in order to actually do better for it.
Thank you so much, Chris. And Jonathan.
Yeah, I mean, I would just say, similar to my esteemed colleagues, it's, what is your data not telling you? Who's being left out? And then to Chris's point, don't be afraid to do it differently, like shake it up and do something different. And it can be uncomfortable, but oftentimes you really get the payout on the other end. Absolutely.
Well, here we are at time. Thank you all so much for sharing your wisdom, experience, your intentionality, your humility with us today. There's clearly much more conversation to continue to have here, and we'll encourage folks to continue to reach out with questions, continue to share with one another as you learn from your own work in this area, and really just appreciate folks spending their time with us today. We're all in early stages of figuring out how to do this work well, and appreciate these opportunities to come together and learn and share what we don't know, as well as what we're starting to figure out. I would ask our audience if you have a moment to please kindly fill out the evaluation that will pop up on your screen following this event. That helps us continue to develop events like this that meet the needs that you have. And lastly, I just want to thank the California Healthcare Foundation once again for making today's webinar and the companion brief possible. Thank you all for all of the important work you do, and look forward to our next opportunity to be together. Thanks so much and have a great day.